My name is Allison, though. I'm with the Michigan Parkinson Foundation. Mary Sue and Emily had obligations tonight, so I'm hopping on for them. But we have both Kaylee and Leigh, and they are both speech pathologists with Leigh Harper Speech Services. So they're just going to go over some stuff with you guys tonight, and then we will allow about 15 minutes for questions at the end. If for any reason we can't get to your questions, I'm going to throw their contact information on our Facebook page tomorrow so everyone can reach out to them as well. So Leigh and Kaylee, if you want to go ahead and get started, I'll go ahead and get everyone muted and we'll go from there.
Sounds good. Leigh, do you want to introduce yourself first?
I'll just do a quick one.
Yeah,
I'm Leigh. I'm originally from Texas. I have been a speech language pathologist and a variety of settings, outpatient, inpatient, acute, and then recently private practice. Love what we do, love treating our patients with Parkinson's. We do adults and pediatrics. My background is primarily adults. I do just like to dabble in kids to keep my skill set sharp.
Yep. All right. And my name is Kaylee. I'll be doing the presentation today. I just graduated in last December, so a year ago now, with my master's in speech language pathology. And shortly after that, started working with Leigh at the private practice and love working with both adults and kids. So we're going to give a presentation on speech and Parkinson's disease and how we can help with voice and swelling and cognition. All right. Sure. So can everyone see this? We good? Leigh, can you see it? Good. Okay. All right. So talking about some of the symptoms of Parkinson's disease, these vary and differ from person to person. So one person may have it and the other person might not, and someone may have it more severe than another person. So early symptoms include a tremor in one extremity, shoulder pain, foot cramping, constipation, sleep disturbances, and reduced writing size. So often we'll see, making the bigger movements and going to smaller writing. And then the 4 cardinal symptoms, which those are the primary symptoms of Parkinson's: the resting tremor, and they call it a pill rolling tremor. So with your index finger and your thumb, typically that happens when your body is relaxed. And then slowness of movement, impaired balance and posture, and then rigidity as well. And then there's also, so there's motor symptoms and then there's non-motor symptoms. So these would be, examples of the motor symptoms. So that tremor, the rigidity, slowed movement, postural instability, whereas the non-motor might be sensory changes. So often it can be with your sense of smell or touch, and then cognitive changes as well. And that can be memory, attention, which we'll talk more about in a little bit too. And then these are just some fun facts. So April is Parkinson's Awareness Month, and James Parkinson's birthday is April 11th. And then Parkinson's is characterized by reduced amplitude of movement. So everything kind of just gets smaller. So smaller walking, so having that shuffled gait, smaller writing, so micrographia, so just writing really small, smaller voice, so just having that reduced loudness. So quieter voice, you might hear mumbling, just lower and smaller amplitude of movement of everything. And how Parkinson's disease is diagnosed. So typically these are all, it's a comprehensive exam. So, taking case history, completing a neurological exam. There's some tests done, CT scans, MRI, blood tests. Those do not diagnose Parkinson's alone, but they help rule out other disorders that might look like Parkinson's. And then typically the way that they diagnose is taking the case history, neurological exam, and then clinical observation. So if you're presenting with those 2 out of 4 cardinal symptoms that we talked about, that resting tremor, slowness in movement. So if you have 2 out of 4 of those, they typically will diagnose you with Parkinson's. And then also they look for having a positive response to Parkinson's medication. So there's different medications that they try for that, including like deep brain stimulation as well. And then the DAT scan is just technology that kind of measures the levels of dopamine in your brain. So we'll talk a little bit more about that too. All right. And so right now they're still researching, causes. There's not exact causes right now, they're unknown, but they suspect, environmental and genetic factors, but it's still being researched. But they do know that with Parkinson's, the neurotransmitter called dopamine in your neurons die or start to become impaired. So typically, by the time a person actually starts to show motor symptoms, so that slow movement or reduced loudness in talking, 80% of the dopamine has already been lost in those cells. So dopamine is that neurotransmitter, and that transmits impulses from one neuron to the next. And we'll talk a little bit more about that, but that's just how your brain kind of communicates with each other to control those automatic muscle movements. So, having less dopamine, the automatic movements are disrupted and they don't become so automatic anymore. And automatic movements include speaking, walking, swallowing, and I think, on the next slide. So walking, talking, swallowing, blinking, the arm swing when you're walking. Those are just some examples. And speaking is actually a highly automatic behavior. So it's something we don't have to intentionally think about. It just happens. Whereas people with Parkinson's, though, they have to think intentionally about speaking and walking, making those movements. So just to give a little short background of how our brain kind of works. So there are billions of neurons in our body, in our brain, and the neurons just receive information and pass on that information to another neuron. So that synaptic gap in between. Did you say something? Are you good? Good. Okay. That synaptic gap in between the neurons is where the dopamine comes into play. So that's normal in humans for that gap to be there. But this is where the dopamine is released and helps transmit information between the neurons so that they can communicate and make those strong connections. So dopamine helps transmit those electrical impulses that control automatic movements. So since people with Parkinson's disease don't have enough dopamine, it becomes difficult to produce those automatic movements like talking, walking, writing. And then on the axon, that yellow in the picture, that myelin sheath, and that's just a fatty substance around the axon, and that strengthens the connection so that actions become more automatic. So for this, a lot of repetition, so in exercise, that can build up the myelin sheath, and that makes those actions more efficient and quick. So that's why many exercises for speech, voice, cognitive swallowing require frequent and consistent repetition. So having that repetition just builds that. I'm sure you've heard like the neuroplasticity rule, use it or lose it, that in the repetition that just kind of builds that so that we can continue making those strong and quick connections and communication. And this is what I just explained, how dopamine is released into the gap, acts like a bridge to help communicate the information between neurons. And then this is just a little fun fact. So 90% of people with Parkinson's are at risk of developing a weak voice that can lead to serious speech and swallowing difficulties. Treatment with a speech language pathologist can help improve the clarity, strength, loudness, and breath support. So we need all of those things in order to speak. So your breath support actually has a lot to do with how we speak. So we'll kind of talk about that a little bit more too, how those all work together so that we can produce a nice, loud, clear voice. And this is talking about how we have two different motor systems. So there's the extrapyramidal system, which is the automatic system, and then there's the pyramidal system, which focuses on intent. So the extrapyramidal system is our automatic movements, so without effort, which we've talked about, the walking, talking, whereas the pyramidal system focuses on intention and purpose. So that's some examples might include like driving on the highway when it's raining out, you start to really focus on what's in front of you. You're being intentional and purposeful, putting on makeup, learning to play the piano. So when we talk about this treatment for Parkinson's disease, we'll actually be using our pyramidal motor system where we focus on intention versus automatic movement so that we can start to learn those movements again. Let's see. So some early signs of a speech disorder, reduced vocal volume, so just talking with a quieter voice, and oftentimes it's typically your main communication partner, whether that be a family member, caregiver, spouse, that notices your voice is starting to get quieter in conversation. Another early sign would be a hoarse sounding vocal quality, frequent throat clearing, especially after drinking or eating, trailing off at the end of sentences, so kind of mumbling, just not really articulating your sounds and words as much as you previously were, and then inconsistent production of the voice. So a lot of times we have people, whether it be your significant other, caregiver, whoever, come in and say, in the morning I can hear them fine and understand them, but at night I can't. And that's that inconsistent production of the voice. So we kind of have to look at the whole person and figure out why that's happening. But there's many factors that it could be, like it could be the voice, it could be your breath support, posture. So when we do our treatment, we're always modeling that good posture, using that loud voice. And then sometimes we also include that respiratory exercises too, to build up that breath support to help us produce that loud voice. So these are the two main evidence-based treatments for speech and Parkinson's disease. So there's Speak Out, and then there's LSVT Loud, which is the Lee Silverman voice treatment. So we do both at Leigh Harper Speech Services at the clinic in Heartland, and they both can be modified for telehealth as well. So Speak Out emphasizes speaking with intent. So kind of like we talked about with that pyramidal motor system, we incorporate that system and we focus on intent and purpose. And it converts that speech from the automatic movement to the purposeful and intentional act. And with Speak Out, we start with a warm up. We do some sustained ahs. So you're just holding ah as long as you can. So you're going to use a nice loud ah. So taking a deep inhale, ah, and we measure how long you're able to do that, and lots of repetition. So both Speak Out and LSVT Loud include lots of repetition. And also Speak Out includes glides. So starting low and going all the way up and back down. So and practicing that. And that helps with intonation, which is just varying the pitches in our voice. So, when we're having a conversation and I am really happy and excited, I might use a higher pitched voice and vary that intonation so that I can relay that, emotion in my voice. So that helps practice varying the pitch and intonation so that we can relay different messages. And then there's counting exercises, reading, and then speak out also incorporates a cognitive aspect. So some other symptoms we'll talk about you might see is a cognitive decline in areas of memory, attention, executive functioning. We'll talk more about that. And so that incorporates that cognitive exercise, and that it's a different exercise each week. So there's a lesson in the Speak Out workbook, and you'll do that each session. So for treatment with Speak Out, they're 45-minute sessions, 3 times a week for 4 weeks. So you get a workbook, and you do 1 lesson in the Speak Out workbook 2 times a day for 25 days. So there's typically do it with a speech language pathologist, and then you have carryover activities that you'll do at home as well. And then LSVT Loud focuses on being loud and using that loud voice. So we work on increasing vocal loudness, improving speech intelligibility and articulation. So focusing more on, having that precise articulation and those motor movements with speaking, improved intonation, improvements in facial expression, and changes in neural functioning related to voice and speech. So for that one, we're also doing the sustained ahs and glides. But then we also create functional phrases that you use in a day-to-day basis. So, it could be good morning, or I have a client who loves Tim Hortons, so she asks, can we go to Tim's every morning? So that's one of her functional phrases. So we just we base it on things that you say daily, and we create those so that they're functional for you to practice in your loud voice. And then there's also a reading exercise with that one. So this one doesn't have the cognitive aspect to the treatment, but that's something that we can always add on in sessions otherwise. So this treatment is a little bit more extensive. So these are 60-minute sessions 4 times a week for 4 weeks. And then there's daily homework practice and carryover skills as well. So lots of repetition for both of them. But like we talked about previously, that repetition builds up that myelin sheath in our brain, and that's what helps us create these automatic movements. So we want to be consistent and frequent in our practice. Let's see. Okay, so this is just breaking it down a little bit. So they're both research-based, like I said. So they can both be adapted for telehealth. So we do see a couple of patients via telehealth and still able to do the Speak Out or LSVT Loud. And in terms of whether you pick the Speak Out route or the LSVT Loud route, kind of just depends on, the symptoms that you're having, your schedule for sure, because they differ in their scheduling requirements. And then kind of like caregiver report too, or spouse report, whatever, whoever it may be that you're with a lot. Because if you have more of a quiet voice, you might aim more for the LSVT Loud, where we repeat and frequently practice using that loud voice and doing all of those vocal exercises. Whereas if you're kind of mumbly and having that cognitive decline in there too, we might head more towards the Speak Out route, where we can incorporate that intent and that cognitive aspect as well.
Both of these programs, I'm just going to add a little piece. Both of these programs are fabulous, and they're very efficacious. You are able to repeat them at any time. So in the past, you might have done it, this year you might do it, and then, you might say, hey, I'm starting to notice a decline. You can come back. Just because you've done it in the past doesn't mean you can't do it. That being said, it does have, the research shows that it has, if you continue these exercises, you have that in your storage bank. And you can do the exercises at any time, because you're going to get probably pretty annoyed by the end of your 16 visits because you're doing them so frequently that okay, I'm starting to get quiet. I'm going to pull out those exercises that I know how to do and work on it myself. So it's also a nice tool to put in your toolbox for down the road. Doesn't mean you can't come back to a speech language pathologist, whether it be us or anybody else that's certified, and repeat the program. Another big thing that a question we get is, we are not vocal trainers. So just because we might be doing highs and lows does not mean you're going to repeat fingers. You do not have to have a good voice, a singing voice. I will be the first. Kaylee and I will both be, we laugh at ourselves. We laugh a lot with our patients. It's really just to get that more of a naturalistic flow. So we push you outside your comfort zone. It's a private session. Nobody has to hear you doing these pitches if your voice cracks. But just know that we are not here to make you singers. So those are kind of the two questions sometimes we get with these two programs.
Thank you for that. I always forget to add that. I always joke with my patients that we're going to be pro opera singers after this. But I got a lot more work to do if I was going to do that. Okay, so this is just talking about the automatic versus intentional speech. So like we talked about previously, those two different motor systems. So the pyramidal and extrapyramidal, one focuses on automatic, where the other one focuses on intent. So speaking with intent actually uses, so your pyramidal system, and that's less dependent on dopamine. So that's why we're able to focus on being intentional versus automatic. So use of intent, it just says walk with intent, write with intent, and speak with intent. So like we talked about before, we kind of see that smaller shuffled gait, writing smaller, and then your voice also becomes quieter. So being able to focus on intent and purpose, we're able to focus on making those bigger movements with walking, writing, speaking, swallowing, whatever it may be. And then this is just a treatment model for all therapies. So just showing that meeting every 6 months is ideal. So having that initial eval, having treatment, and then 6 months re-eval, and kind of every 6 months kind of checking in just to make sure, you know, you're still doing well and you're not seeing that decline. And like Leigh said too, it's a good thing to add to your toolbox. So you can just pull it out, but it's good to also reassess with your speech language pathologist every 6 months, just to try to check on things and make sure you're not missing anything. So, and this just says daily home practice with weekly speech exercise groups and support. So through LSVT Loud and Speak Out, I'm pretty sure there's both support groups with that as well, that we can provide information to when we provide the other stuff as well. Okay, so we got questions about what can I do right now to improve my speech. So whether you're early on with Parkinson's or you're later, there's many things that you can do now before seeing a speech language pathologist or before you're able to get in. Just making number 2, exaggerating the sounds. That's one of my favorites. So like we've talked about, we could talk like this and the mumbling, and you're not really articulating and using your motor movements as big. So exaggerating the sounds it's extra, you're really exaggerating, but it helps move your muscles of your tongue, your lips and mouth to really formulate those words and concentrate with intent on that precise articulation of those sounds. So opening your mouth more when you speak, that also just kind of comes naturally when you're exaggerating the sounds as well, but just focusing on that. Separating words and syllables so they don't run together. So slowing down a little bit as well when you're speaking, and then speaking loudly enough. So especially when it's noisy, so at, you know, a restaurant or where there's background noise, you have to be really intentional with your loudness of your voice, you know, taking breaths in between so that you can have that good respiratory support to be able to project your voice. And then be concise, so using fewer words when you communicate versus, you know, being lengthy and not, you're running out of breath and then you're kind of getting tired towards the end of your sentence. That can help as well. And then practice speaking materials, so of serial nature. So this is like the alphabet. So that's kind of an automatic thing that we've learned, you know, the days of the week or days of the month. And then when you feel like you're running out of breath, like I just said as well, taking that inhale, and that's okay, you know, to take that breath and take that break before you continue on with your message of whatever you're saying. So another thing as well too, another good thing to practice would be reading aloud daily too. That can help with the respiratory and laryngeal muscles. So our vocal folds in our throat, and how we speak, that can help those muscles as well. And practicing reading aloud in a loud voice daily is a good thing to do as well.
And these are all things you can do right away. And you can do them almost as like a practice, and you can set yourself up and sort of test to see, oh gosh, I can, on one breath, I can count to 4. And my wife says it's loud. It's loud enough. Okay, so then you know, okay, I'm going to do this every day, count out loud, you know, 5 or 10 repetitions, and see if I can't by next week get to 5 or 6. And then just keep going. Or I'm going to say the Pledge of Allegiance, and I take 4 breaths when I say it. I want to try to do it in 3 breaths to support that underlying speaking mechanism. So you're almost setting yourself up for therapy independently. So there's lots of things you can do by yourself that are not magical. Pretty simple.
Even though we like to think we're magical. We're not. All right. So another symptom or early sign that you might see with Parkinson's disease is called dysphagia, which is a swallowing disorder. And that's just because, you know, the muscles that we speak with are also a lot of the same muscles that we eat and swallow with. So kind of seeing that they can both kind of work together. And this is just a fact. So aspiration pneumonia is reported as the most common cause of death in Parkinson's disease and is estimated to account for as much as 70% of mortality rate. So the big thing with dysphagia is we want to prevent it. So providing the education and strategies to prevent that from happening. And let's see. Okay. And these are the early signs of a swallowing disorder. So drooling or coughing. So especially right after you're eating or drinking something, feeling like you have food stuck in your throat. And even when you clear it, it just doesn't go away. It just feels like something's stuck there. Unexplained weight loss. So these are the first symptoms of muscles losing coordination would be like that coughing and throat clearing after eating and drinking. And like I said, a lot of the muscles that are used for speaking are also used for swallowing. So that's why we see that commonly together. And then these are just some treatment and management. So what we will do, in therapy as well. So therapeutic exercises, compensatory strategies, positioning maneuvers, and diet and liquid modification. So we'll provide this presentation as well, but there's a dysphagia fact sheet on here that you can click on as well. And I think that might be in the handouts, right, Leigh? Okay, yeah. And so these are just some therapeutic exercises. So there's lots of different ones. One I can quickly show you is the effortful swallow. So that's just a dry swallow. So trying to squeeze all of your throat muscles and really like put in a lot of effort to swallow. So And these all kind of build swallow muscle strength and control, and improve the contact and coordination of your muscles in your throat and areas over there. So
one of the things we would encourage you not, so we included these lists of therapeutic exercises and compensatory strategies. More for like, if you're interested in doing research, you might have heard of some of these, but not all of them. But if you truly are experiencing some of the symptoms of a dysphagia and you're a little bit concerned, I do not go and try to do all of these or try researching and just say, oh, I'm going to pick a few of them. They work. They're very research-based, and they work specific musculature related to your difficulties. So there are different tests, which Kaylee will talk about, that let us know, ooh, this person is presenting with these signs, which means XYZ muscle is weak and we need to strengthen it, or not coordinated. So there's differences in coordinating musculature and building strength. So don't try to do, those muscles are very fast twitch fibers, so they fatigue quickly. So if you go and just say, oh, I'm going to do a few of these and I don't need to see anybody, I would recommend not doing that. You won't do more damage, but you might not do any good. You might be working really hard for nothing.
Thank you for that as well. So like she said too, these are compensatory strategies. So these are some things that we would do in therapy, and they're simple alterations that we can make when swallowing. It doesn't change, the actual function of the swallow. It just kind of helps alter the swallow when we use them during, whether it be a liquid or regular food solid swallow. And then also diet modification. So we use the IDDSI, which is International Dysphagia Diet Standardization Initiative. It's a mouthful. But it's just a common tool that everyone can kind of make sure that if you have dysphagia, it describes the food and food textures and liquid consistencies and thickness to improve safety for swallowing if you do have dysphagia. So just making those diet modifications depending on, what symptoms you're having. So like Leigh said, don't go through and, oh, I'm going to, have these thin liquids because I feel like I'm having difficulty swallowing these regular solids. There's different symptoms that we will assess, and that kind of determines what diet modifications need to be made. So typically we'll make these diet modifications if needed to improve quality of life. And then also at the bottom, there's the framework. There's a link to that as well. You guys can click on when you have the presentation.
Diet modification specifically for speech and swallowing, not for
yes.
If you're having difficulty nutrition, hydration, that's more you should go to a nutritionist or go to your primary care doctor and let them know you're losing weight or you're vitamin D deficient. That's not our cup of tea. Mm-hmm. We are specifically the anatomy and physiology of swallow muscles, not as much like gut health or nutrition.
Yes. Thank you. And then here's the cognition aspect. So there's lots of different things that can start to become affected with Parkinson's disease. So these are just some examples. Cognitive fatigue. So your brain just works harder. So, things like taking breaks. If something becomes too hard, give your brain a break. That's okay. Attention. So setting a timer might be something that's helpful so that you can attend to this, task for that period of time. Using sticky notes to bring your attention to something as well. Orientation, so hanging a calendar. So at work I think I have like 3 calendars that I use. And so just trying to orient where you're, what day it is, what you're doing that day. And typically like crossing off dates as they go to try to keep track of that can help as well. And then there's processing speed, word finding. So lots of like puzzles you could do. So like reading crossword puzzles, problem solving, you could do Sudoku puzzles, we do a lot. So there's like the online versions and the paper versions, and they, differ. So those are good as well to focus on that. Executive function. So that can include, task initiation, and so I have some patients that have difficulty with task initiation. So, if they tell me they want to clean their kitchen, actually that's a really big task. If you want to clean your kitchen, there's a lot of steps that actually go into that. And so we have to break it down so that it doesn't seem so overwhelming, and that we can take those little steps to actually initiate and get started on that task, and see follow through. So, example, they might want to clean out their cabinet. So, let's go through the steps of what we need to do to clean out your cabinets. And then something with, if you have difficulty with, remembering that you want to do it, or that task initiation, a significant other or caregiver, whoever can, leave that cabinet open so that it's kind of that visual reminder for you, oh, I wanted to organize or clean out those cabinets. So making a schedule, kind of breaking down tasks and modifying them so that helps you get started on that as well. And memory deficits, so things that can help with that, labeling or making or putting things in specific areas. So always putting your keys in your wallet in the same spot, so that you don't forget, or you're heading out the door, your keys are right by the door, so I'm going to grab those when I go out. And another thing would be making a memory book. So those are person specific too, so we can make those in therapy as well, and they kind of just help you recall day-to-day information. So, it might be medications and prescriptions like that, it can be a lot to manage. So making sure, okay, I'm going to take this medication at, this time in the morning, this one at night, doctor's appointments, weekly schedules, bills, phone numbers, whatever it may be, that can all go in that memory book. And that's something that you can carry around with you everywhere you go. And then language abnormalities. So that's like following conversation. So identifying humor and sarcasm. Some people might not be able to catch on to that as quickly. And then visual spatial difficulties and kind of safety awareness. So, rugs on the ground, kind of just making sure that they're able to see that so that they don't, trip and fall. We don't want that either. So, and then always that social emotional component as well. So, a lot of times, you might become depressed or anxious, feel isolated and alone. And that's something that, like, these support groups, it's wonderful that you guys are all a part of that, having family and friends to talk about memories and experiences with can really help with that as well.
With the cognitive component, we really want to catch it. If we can catch it earlier in the disease process, that's better. So we can get these strategies and implement these strategies earlier. And so they're, again, more effective. They're deeply ingrained. You have that myelin sheath built up, so they become more automatic and you become more independent. A lot of our patients come to us and they're like, I ask for something and then their significant other will answer for me or answer for them or fill out the paperwork. And I'm wondering, why is my patient not doing that themselves? I want to give you that autonomy back. So even though it might take longer to find a word, longer to complete these tasks, and that might frustrate the significant other because it takes a little longer, that's good. That is your brain working to build those pathways. So we really work with, the person, our patients, but the families as well, to support that patient autonomy. So you retain that independence as long as possible. That is our goal, to keep that quality of life. So this cognitive component is really early it's it's important to address early in this disease process. So
Yes. Okay, so this is the rehabilitation and compensatory strategies. So this is kind of what I just talked about, using that calendar, memory book, making lists, sticky note reminders, pill box for medications to kind of keep track of that. And then home program, which we are, will that be linked as well? Okay, that's going, you'll see that as well on the Facebook page, or however you guys will get that. And some exercises to exercise your brain, and then practice mindfulness, and move and learn. So whole brain exercise or brain gym. So that's kind of, if you haven't heard about that, that's just kind of integrating the right and left hemispheres together to work both sides of your body and your brain. So it focuses on like rhythm and timing, attention, and coordination. So those are really good exercises to do as well. And then this little fun fact: when we repeat an action over and over again, we strengthen those connections by insulating the axons with a fatty substance called myelin sheath. So that's, you know, what we've been expressing this whole time. So that repetition and consistency is what we want to create these intentional and automatic movements. And then, so find support, ask questions, be prepared. So like we kind of talked about at the beginning, everybody's symptoms differ. So there's no one size fits all, especially when treating speech, voice swallowing, and cognitive with Parkinson's. So if you or a loved one has concerns, it's important to ask questions and, you know, seek services with a speech language pathologist. And we always encourage the earlier the better. We want to prevent more than, you know, catch it at a later time in the disease, because that can always help the progression and everything faster. So always think safety first, and we always want to focus on, you know, improving quality of life. So that's kind of what our services will be around. And I think now we get to the questions. So if anyone has any questions, feel free.